Hello, everybody, and welcome. Thank you so much for your patience today. We've had some technical difficulties, but we do have our presenter here today. He's just taking a quick break, but he'll be back in just a second. Again, thank you so much for joining us today, and welcome to the ICA Monthly Speaker Series, Navigating IC BPS Conversations with Experts. We are delighted that you're here with us today to learn more from Dr. Christopher Smith, a board-certified urologist who specializes in male and female urinary incontinence and voiding dysfunction. Before we start, I have a few housekeeping items. Please note that this session will be recorded, so if you are on camera, your video will be included in the recording. We will have a Q&A session following the presentation. So to ask a general medical question, which is not personal, throughout the session, you can go ahead and use the chat feature in Zoom. And once the Q&A session is actually started, you could also use the raise hand feature. So it's up to you if you want to just send it through the chat or if you want to raise your hand, and then we would unmute you and you can ask your question. When you are not speaking, please be sure to stay muted. Dr. Smith will answer as many questions as he can in our hour-long webinar. And finally, please complete the post-webinar survey. A link to the survey will be posted in the chat. So without further ado, please go ahead and help me welcome Dr. Smith.
Thank you very much. I appreciate that. I was going to start by giving a short presentation. I did want to describe my 20-year experience with Botox. Can everybody hear me okay?
Yes, we can hear you.
Yes.
Okay. So, saying unmute myself. I don't know why the host is wanting me to unmute myself. But so I've had 20 years of experience. I did, just a little background, I did my medical school at Northwestern in Chicago, 4 years there, and I did a 6-year residency at Baylor College of Medicine down in Houston. And then I did a 2-year fellowship in neurourology and female urology. It was an NIH fellowship at the University of Pittsburgh. That's where I met my mentor, Michael Chancellor, who really introduced me to botulinum toxin. He was one of the first really in North America to use that and really a pioneer in the use of botulinum toxin. Now, it was first, really studied and used for neurogenic bladder in the urology population because it's known as a neurotoxin that affects the release of transmitters from the efferent nerves, which control motor function or muscle movement. So it's really useful for spasticity. But we were also interested in looking whether it could have sensory effects on the pain fibers or sensory fibers. And so we did a lot of research within his lab. It was an NIH fellowship, so we did a lot of basic science experiments and showed that it did have an effect on inhibiting some of the sensory neurotransmitters. And it was from that research and clinical experience in Pittsburgh that I transitioned back to Baylor in 2002 and really started my journey with use of botulinum toxin. And that's when we first started using it in patients with interstitial cystitis or painful bladder syndrome. And we were actually the first ones to publish on its use when we talked about the anti-nociceptive effects of botulinum toxin in patients with interstitial cystitis. It was way back in 2004. It was a multinational small case series of 13 patients that we treated and we published in the Urology Journal. So I've had over 20 years experience with use of botulinum toxin. I treat both men and women with not only overactive bladder, but painful bladders and chronic pelvic pain. It is obviously it's included in the algorithm for interstitial cystitis. It's let's say not the first option. Obviously, you try less invasive things first for the most part and kind of move from there. But in patients that have significant symptoms, they haven't been helped by conservative measures, oral medications, dietary changes, pelvic floor therapy, even intravesical treatments, then I think that's when botulinum toxin has a role. Patients I've treated, that continue to be treated, it doesn't necessarily cure them of the symptoms, but it allows them to have some control where the pain flares are not as severe and maybe not as frequent. So that's kind of been my journey with use of botulinum toxin. I think, in the past, in that same realm, you can do sacral neuromodulation, and that is a fourth or fifth line option. I initially probably used that more in patients with painful bladders, but I found that it was not as effective, and I found that botulinum toxin in my hands, is much more effective in this population. So I was going to, show you some slides, just a little introduction that obviously, these chronic pain conditions can be in men or women. They can include both bladder pain as well as, genital pain. And then in men, it can include, typically includes penile pain or pain in the perineum. But both populations can be improved with botulinum toxin treatment. Usually for women and for some men, I'll do it as an outpatient procedure where I'll do a hydrodistension, stretch the bladder, and then typically in women, I'll inject the bladder as well as the urethra. And if they have pelvic floor pain, I'll inject the levator, pelvic floor as well. In men, I can do it if they have a lot of bladder symptoms. I'll also do it in the operating room where I do a hydrodistension, inject their bladder, but I also will inject their prostate and their external urethral sphincter. I can also, in men, also will do some injections in clinic via the transrectal approach, where I can inject their prostate, their levators, as well as the anal sphincter and perineal body. A lot of men will have symptoms more targeted in the pelvic floor and even in that area that I can inject just with a little spinal needle within clinic. So that's kind of my experience with it, how it evolved, my background and use of it, how it really started from my research during my fellowship and first use clinically, and then how it's transitioned into the clinical population. There have been, several smaller studies looking at its use in interstitial cystitis, even some randomized trials that show benefit, but nothing, it's not FDA approved for this indication, so obviously it's off-label. But many of the treatments that we do for patients are off-label. We find, a benefit and can apply it in different areas as well. I guess with that, maybe just open it up for questions if anybody has. Be happy to entertain them.
I have a question.
I have a question.
Sure. You do want you go ahead. You want to identify yourself?
Yeah, my name's Tony, and I've had IC for approximately 27 years. And the last few years, I've developed pelvic floor issues. And my urogynecologist from the University of Pittsburgh, we've discussed how to handle some flares. And I wanted to see, how is it, number one, how is it different, the Botox, as opposed to, there's like a nerve block that she mentions, and two, what are the dangers of incontinence, to even temporary, with the Botox?
Good questions. Very good questions. So I think the nerve block she's talking about, maybe a pudendal nerve block. So that would be something
Yes.
where she would give probably a local anesthetic, maybe a steroid combination or one or the other, and inject the pudendal nerve. So that would give like a temporary block. It wouldn't, it's not going to last for a long period of time, right? So it would maybe be a good way, diagnostic maybe, to see if that's what's affecting it, maybe also therapeutic. Perhaps the steroid would have a more of a long-lasting effect. What we do with Botox injections, we're targeting, we're injecting the muscles, but it does target the nerve. So what botulinum toxin does is it actually inhibits release of the chemicals or neurotransmitters from the nerve. So it blocks release. So on the muscle side, it blocks release of the chemical signals that causes the muscle to contract. So if you give a small amount, it'll kind of weaken the muscle. If you give a strong enough amount, it could actually, paralyze the muscle. Now it is temporary; it does wear off. But we also looking at it from a sensory side. So not trying to block muscle, but trying to block the sensory nerves, the pain fibers that release these chemicals that cause a upregulation or increased activity of those nerves. So it's kind of a concept, I don't know if you've heard before, like called neurogenic inflammation, but where, activation of these sensory nerves could play a role in really winding up these pain pathways, so that on patients with IC or chronic prostatitis, chronic pelvic pain syndrome, just a normal stimulus like the bladder filling becomes painful because it's activating these pain fibers. So a normal person would just feel like, hey, my bladder feels full. But for a patient with IC or chronic prostatitis, chronic pelvic pain syndrome, they feel a painful urgency. And that's a little different than patients with just overactive bladder. Patients with overactive bladder will have an urge to urinate because they have a fear of leakage or incontinence. A patient with IC will have a painful urgency. They go to relieve the pain. So I think that we're targeting things a little differently. That with the effect of Botox is going to be more of a what we call neuromodulation. It's not going to be an acute effect. You get a pudendal nerve block, and it's going to work right away. You're going to, have that numbness in the perineum and that saddle area, like when you sit on a saddle on a horse. But it's going to kind of wear off over a period of hours or days. The Botox effect takes a little longer to kick in, so it's going to take a week or two to kick in, but it's going to last longer and last anywhere from 3 to 6 months, depending on the patient and what's going on. Now, as far as side effects, incontinence, that could be an issue. So I have seen, particularly in women, that you can have some stress incontinence, but it's usually patients that already have stress incontinence. It can exacerbate it a little bit and make it a little worse, and that's usually a temporary effect. My kind of paradigm how I injected patients was I initially just started injecting the bladders of patients, and the patients would come back and say my bladder pain's better, but I'm having some difficulty urinating. And that's one reason why when I do my bladder injections, I only inject a specific location of the bladder, the trigone, where all the sensory fibers are located. I'm not trying to have a muscle effect like you would for someone with overactive bladder, where you spread the injections throughout the bladder. I'm just focusing it right on the sensory nerves, which are really more densely populated in the trigonal area. So, but that being said, just by injecting the bladder, some patients would say, I'm having some difficulty voiding. So they also would have some urethral pain. So I started injecting the urethra as well. Patients then came back. These are more female patients I'm talking about, and would state that they bladder pain's better and their voiding better, but they still had significant dyspareunia. And that's when I started adding in the pelvic floor injections. So that's the typical template. And, I've had some women that have the stress incontinence at baseline that can get worse with Botox. And then a lot of times we'll do a procedure, a little sling to help treat the stress incontinence. But I have, decreased the dose to help mitigate that. I would say most times it's a temporary. It usually lasts for a couple weeks and then wears off. I don't know if that helped to answer your question or not.
Yeah, I was worried that it would numb and you'd need to be catheterized because it would numb your ability to void.
Retention issue. Yeah. So there's always a risk of that when you have Botox. There's always a risk that it could do that, and I try to prevent that. I would say it's happened a few times. I've done a lot of patients. I'm not saying it never has happened. It's happened a few times in patients, and where they've had to temporarily have to catheterize. But I try my best to prevent that by, like I said, just injecting the bladder in that specific location with the lowest dose, just 100 units, and also injecting the urethra to help empty better. I would say that for the most part, patients, even the ones that had it catheterized, because their pain improved significantly, for them it was a worthwhile trade for that, because they were so bothered by the symptoms that even if they had it temporarily catheterized, it was a worthwhile trade-off.
Thank you.
But good questions. You need to understand the potential risk.
Dr. Smith, we have a few questions in the chat. I don't know if you can see them or if
Sure.
you would like me to go ahead and read them out to you. I can do that.
You want to read them? Yeah. Why don't you read them for me?
Okay, we have a question from Linda. What is the difference between calcium glycerophosphate pre-leaf and calcium carbonate?
That's a good question. I don't know if I have that answer. I don't know if anybody has experience out there.
Okay.
I know that for a lot of patients that for the pre-leaf, that's an option. Some patients that want to have, be able to partake in some dietary, regimens that maybe would irritate the bladder. If by taking the pre-leaf before, that would help them out with it. But I'm not sure that the difference, between those two specific. But if anybody else has it, sure.
Okay. The next question is from Maggie, which actually I'm going to take this one. She asked if there's a special diet that would be beneficial for IC, and actually that's going to be the topic of our next session. So if you'll see some emails promoting that next session in January about the IC diet. So Dan has asked, do you use any sedation or anesthesia with the injections?
Yeah. So when I'm doing the Botox with the hydrodistension, patients they're put to sleep, because obviously that would be very painful to do in clinic, do bladder injections. But now for men, when I do transrectal, I usually will inject with a really tiny spinal needle. And so in that case, they will, usually I do it actually without sedation, because I use the spinal needle to kind of localize where the trigger points are and do the injections in that area. I know that in some clinics, women, obviously for just pelvic floor injections can be done. They can use some like enema cream or local anesthetic and do injections that way. I would say that the majority of the patients that I inject pelvic floor also have bladder symptoms, so they're done, in an outpatient setting with anesthesia.
Okay, thank you. We have another question asking if the body ever builds tolerance to Botox to where it doesn't work anymore.
Right, it's a good question. So there is potentially a risk that the body will develop antibodies against Botox. I would say it's much less likely now that because Botox came out with a newer formulation several years ago that had lower amount of protein. In each vial of 100 units, there's only 5 nanograms of protein, so it's a very, very small amount. And that's what your bodies would recognize and form antibodies against. So I would say that it's possible, and but I don't think I've really seen it, to be honest. I mean, some patients maybe would need to be treated more sooner, I guess. So maybe that would be maybe a sign of not working as well. But I wouldn't say they totally failed. But that's a potential. So there's a potential for that. So that's why we never want to treat less than 3-month intervals, because that would increase your risk of forming antibodies and then not responding to Botox in the future.
Okay, thank you very much. We have another question from a marathon runner who always feels pelvic floor pain when running and gets relief after urinating, but then in 5 to 10 minutes feels the pain again. And he's wondering if Botox treatment is appropriate for this type of an issue.
Right. I think it would depend. Obviously, it's hard to give advice, over a chat without, seeing a patient, knowing the history, doing an exam. And like I say, we always don't necessarily start with Botox. We would try other things first. You would try, medication, dietary changes. You try physical therapy. The patients that, come to me for Botox are usually the ones that have, exhausted these options, and then, they've tried these things, haven't gotten relief. And that's at that point, that's when we're looking at Botox as an option. So potentially, I have treated patients with symptoms as that patient describes, but I don't know where where on the treatment paradigm, he or she is.
That's an important clarification. Thank you for sharing that. I think that's important for everyone on the call to know. So if you're a newly diagnosed person, there's many other options that you should be trying before you turn to Botox. Okay, so we have Susan asking, she, on the other hand, has had IC for 26 years and has Hunner's ulcers and fibrotic bands and low capacity. She asks, does Botox help with the fibrosis?
Right. Yeah. I think there's not a whole lot of evidence that it's going to help or hurt it. There's no evidence that it actually causes fibrosis, but there's not a whole lot. There's been a few studies maybe that showed changes, but not enough out there to say that it would. Have I treated a patient that has kind of contracted bladder, Hunner's lesions with Botox? Yes, I have patients with that. Now, will they get the same, response as far as decrease in frequency and urgency as someone without it? Probably not. I think if you have a contracted bladder, then you're going to always probably go more frequently than someone without that, issue. But can you get improvement with Botox? You can still get improvement, right? But I think the one thing we know with Hunner's lesions is that they also kind of the standard of care is to do the fulguration and steroid injections, because that can help, reduce some of their pain symptoms as well. But can Botox be an option to improve it? Yes, it can. Will it reverse the bladder? Not necessarily. I think we're trying to maybe it'll prevent it from progressing further.
Here's a question from Marissa. Can Botox be used in children with IC or overactive bladder?
That's a good question. I have done I have treated patients, children, probably adolescents, probably no one younger than like 15, that obviously has, tried everything and the pediatric urologist they even done like hydrodestensions, things like that, and patients, being admitted over and over again for, epidurals or just, installations, things like that I have done and I've had some benefit with it. But, I haven't really, that would be probably the youngest, probably 14 or 15 years old, but not really smaller. That really falls into the realm of the pediatric urologist. So patients that are kind of maybe adolescents, teenage years, that they're thinking about transitioning or need help with. I've done a few patients like that as well.
Okay, great. Thank you. Someone's asking if Botox is approved by the FDA for IC. Can you speak to that at all?
Yeah. What was the question?
Is Botox approved by FDA for IC?
No, FDA. Yeah, no, it's not approved for IC right now. Currently, no, it's not. Just it's approved for
and we have
approved for overactive bladder.
Oh, can you say that again? That kind of cut out a little bit.
It's so it's approved for overactive bladder, so frequency, urgency, urgent continence, both overactive bladder and bladder, neurogenic bladder, related to someone has a neurologic diagnosis. So more for those symptoms, not the interstitial cystitis symptoms.
Thank you for clarifying that. Keith is asking, how do we get this technique into more regular use across the country? Do you know about, how?
Yeah, that's a good question. Yeah, I think part of it is that it's probably hard now. Number one, without having FDA approval, it's not maybe going to be as widely accepted because it's harder to get approval for patients, and so that makes it more difficult for physicians to offer it. And so I think now you're going to really want to find centers that specialize in these kind of treatments that treat a lot of patients with interstitial cystitis or chronic, pelvic pain syndromes. That's where you may find it available.
Okay, thank you. I mean, we're going back to some of the questions. You had kind of started this list, but someone's asking what should patients try and exhaust before trying Botox? Can you speak to that a little bit more, or?
Yeah, I can talk about it. Yeah, so I think there's first of all, there's two populations of when we talk about interstitial cystitis. We think there's two, the ones with the Hunner's lesions and non-Hunner's lesions. So if you have a Hunner's lesion, then clearly the algorithm states that you really want to go, to the fulguration, go to that kind of procedure, fulguration with steroid injection, because that's one thing that's been shown to be beneficial. But I would say the majority of patients have the IC with the non-Hunner's lesions. And whether we talk about interstitial cystitis or the chronic prostatitis, chronic pelvic pain syndrome, you always want to start with least invasive and progress to more invasive. And multimodal treatment seems to be the most effective. So that means that kind of a multidisciplinary approach. So that means multiple providers, not just a urologist, but it may be a pain management doctor, it may be a nutritionist, it may be a physical therapist, all working together to try to improve a patient's quality of life. But the initial things are always kind of behavioral strategies. So trying to identify the triggers that promote these flares, whether it's a dietary change, whether it's stress, whether it's sitting. A lot of men can be sitting, or bike riders, things that kind of provoke it. Ejaculation for males, all these things. Sexual activity can provoke it as well. So trying to identify what the exact triggers are and seeing if you can kind of mitigate it to make it not as significant of a trigger. And then starting with various medications, right? And nothing is necessarily proven to be better than others. You have to kind of experiment with that and individualize it and see what works for each patient. Also, tying in, physical therapy is one thing. If the patient does have a pelvic floor hypertonicity or increased tone or pain in the pelvic floor, that's one treatment that's shown to be beneficial. So that's something that to add on up front. I would say that, if that fails, if those things fail, then, and there's definitely a bladder component, then we typically move to considering like installations where you can do office installations with medicine that can often get a patient out of a flare. And then, if that doesn't work, then you're kind of looking at doing a hydroextension, with or without Botox, depending on what the patient's, underlying symptoms are and what their desires are. That's kind of how I kind of work my way down.
Thank you. And for the person that asked that question, please go visit ichelp.org, because we have a lot of great information there. So if you haven't already, please start there. Okay, we have a person who's written in and saying they already have trouble just starting to urinate, and they have pelvic floor dysfunction. They've done the therapy, and they have a lot of pain and are very sensitive to triggers. And so they're really concerned about Botox, and they're just wondering, are they right to be concerned, or do you think that they should maybe consider it?
Yeah. So that's a good question. I think if patients, whether it's kind of IC or other conditions, like even just overactive bladder or something, if the patient has a lot of voiding dysfunction where they have a lot of, typically if we do a test like a urodynamic test, you would see that during the voiding phase, the patient, as opposed to what normally they should relax the pelvic floor to urinate, they would then be contracting it. And it's almost like an obstructive type voiding pattern. And so in that patient, perhaps, given that if you inject just the bladder alone, would that put them more at risk for having more difficulty emptying? Perhaps it would, particularly if they already were carrying a large residual to begin with. So if a patient came into clinic and had a history of voiding dysfunction, we typically do the bladder scans in clinic to see how well they empty. If they had, a large, a significant residual, and they had, testing that showed that, I probably would be reluctant to just utilize Botox by itself, because there would be a risk with that. I would probably want to try other measures. Hopefully they would start with physical therapy to see if that can help their voiding behavior. Now, on the other hand, a lot of times patients will have this voiding dysfunction because of the pain, right? I mean, how many patients do you have that say, I have so much trouble urinating in the morning when my bladder is so full. Like, why does that happen? My bladder is so full, I should be easy to urinate. And, and why is it the hardest right then? And it's because the pelvic floor, the pain, you have the bladder pain, the pelvic floor responds by contracting to, kind of to try to prevent that pain, but actually it's actually making it worse. And then when you try to urinate, you can't relax the pelvic floor. So it's like a vicious cycle. You just have more difficulty emptying. So in that sense, if you do the pelvic floor injections, it may help by relaxing the pelvic floor and kind of breaking that cycle. So it really depends. I think all these cases, you really have to individualize on a patient-to-patient basis. You have to have I always have a long discussion about risk and benefits, and even if there are the only thing that I would say with the Botox is that that none of the side effects are permanent. The Botox always wears off, so there will be nothing permanent with it.
That's good to know. We have someone asking, how do you diminish the possibility of retention or having to self-cath?
So we talk. So I would always inject just that one area of the bladder, the trigone area, with the lowest dose possible. We inject the urethra as well to help empty. If a patient had a history of not emptying well, you could start them on medicine to help them empty, an alpha blocker, and that maybe would help them empty. We always train patients on double voiding. We always try to follow up with patients, within the first few weeks after treatment, if they're at risk, to see if they're having any residuals at that point. Patients may notice that they have a little more difficulty voiding, but it doesn't necessarily mean they're going to have to catheterize. And that's the point. So I think the risk of actually having to catheterize is pretty small, but, some patients will notice, I have to kind of sit there a little longer to let it empty. And that's not only for interstitial cystitis, that's even for overactive bladder. So patients may notice it just takes a little longer to empty, but the positive side is it's helped their symptoms so much that for them it's worth it. It's a benefit that outweighs any minor issue of having to spend a little more time in the bathroom to empty.
Okay, great, thank you. We have Ashley asking, how often should an IC patient have a hydrodistension even without Botox to minimize bladder shrinkage? Is that something that you can answer? I wasn't sure.
Yeah, I think that I wouldn't worry about the shrinkage issue, that it's gonna, because I think that the shrinkage is really that population that has a Hunner's lesion. So I think, and I don't think there's any known, risk factor that if you have the non-Hunner's lesion, that you're going to transition into Hunner's lesion. But I would just use the hydrostension is that when you should get retreated is kind of based on your symptoms, right? So if you say, some patients may say, hey, just twice a year is good. Some may say, hey, I just need it every couple of years for a flare. Some may need it every 3 or 4 months. It just depends on, number one, you want to do a treatment that's actually giving you a benefit, right? So that's a point for all treatments for IC. If it's not working, that's when you kind of say, look, let's try something else. We don't want to stick with the treatment that's not working. But if it does work, then you have to determine, how long can you go, before your symptoms return. The one thing with Botox is that it does have a slow onset in relief of symptoms. So it takes a couple weeks to kick in, and usually you kind of see your max benefit at a month. And then it has a slow offset. So it kind of wears off the same way. You'll notice it's starting to wear off after a few weeks. So each patient's a little different. So most patients will not want the Botox to wear completely off where they're back at their baseline, and their symptoms are 8 or 9 or 10 out of 10 pain when they get retreatment. So they'll try to catch it where it's just starting to get worse. Maybe it's a 5 or 6, and then get retreatment to kind of stay in that where they're comfortable. And that depends on each patient. But so the same thing with hydrodistension. You want to, if it's effective for you, then you want to find that interval that's going to allow you to prevent these flares and improve your quality of life, where you're not having to come back down the baseline in between each treatment.
Great, thank you. I've noticed that the questions have been sort of tailing off. I think I have another one or two left for you. So at this point, I just wanted to encourage people, if you do have any lingering questions, you can either use the chat or raise your hand, and we'll get to you. So with that, I will move into a question that I'm not sure if it's one you'll want to answer or not, but I'll go ahead. Someone's asking about neurotransmitters. They've seen something advertised called signal relief patches that claim to address blocking these signals. Do you have any idea if that's something that could work on pelvic pain?
Yeah, I don't have any.
Yeah.
I'll be able to give a statement on that. Yeah, I'm sorry.
Thanks. I wanted to give it the shot just in case that was something you could
Sure.
answer, but I didn't think so. Okay. And then, yeah, I think that's all.
Okay.
Anybody else have a question? Let's just give another minute or so in case anybody wants to raise their hand or add one more question. Okay. I'll go ahead and start with my closing remarks, and if another question comes in, I'll let you know. But so thanks everybody for your patience today. I know that this was not ideal, the start of the session, and we appreciate you staying on and waiting for us to get everything together for you. We will be in touch with you with a follow-up with an email. We will edit out this recording so that you'll have the full session without all the front matter. And we will see about getting you the slides and any videos if we can. So we hope you enjoyed the webinar and learned something new. And if you found this event to be of value, please consider joining us for future webinars and share these opportunities with your community. A friendly reminder to please complete the post-webinar survey that we have posted in the chat. And as I alluded to earlier, we're excited to announce our next webinar with Callie Kreitcher. She will be presenting on the IC diet. Is it a necessary long-term solution? So watch your email for more of that information. Thank you so much for joining us today. And actually, I've got a couple questions that are coming in now. So before we go, let's see. Someone has asked if they've been told their bladder is at 1/3 capacity, would continued Botox or hydrodistension be indicated? So,
say that again. Repeat that.
If I've been told my bladder is at 1/3 capacity, would continued Botox or hydrodistension be indicated?
Yeah, I think it depends. The study, I mean, there has been some research to show that hydrodistensions in themselves don't impair, don't cause fibrosis. So it really is, I wouldn't use it as a means of trying to preserve your capacity, but as a means of, is it improving your symptoms? So if it helps you in reduction in pain or reduction in the frequency that you're having symptom-wise as a treatment, and it's effective and pretty durable, then I would continue that if other things haven't helped. But I wouldn't do it just for the numbers, just to say, well, my capacity is this versus that, if it's not, especially if it's not helping your symptoms.
Okay, great, thank you. And the rest of what I'm seeing, the rest of what I'm seeing looks to be a lot of thank you very much for your time. So it sounds like people were glad they stayed, and we appreciate you, Dr. Smith, coming in and sharing all this important information with us today. Thank you so much.
Sure. Yeah, I apologize for that. The technical difficulties. I'll try to get the slides put together where with the videos, hopefully we can get it where you can actually see, which is interesting because it's actually a video of me doing bladder injections in a female and then doing the prostate and sphincter injections in a male. So it'll give you a little approach. Obviously, you would be asleep, but it allows you to see what I'm doing with the injections during that time.
Okay, that sounds great. All right, well, thank you once again, everyone. Have a great day. Bye-bye.
All right, take care. Thank you.